My name is Marguerite and I'm a registered nurse. I've been a director of nursing and a manager of risk and quality management in the past in the private hospital sector. So I've been through the accreditation process and been assessed and audited myself several times. I did a quick estimate last night and I've undergone accreditation in 4 different healthcare facilities. So I know what the stress and what it can be like on the other side. I have an education background as well. I was a clinical nurse teacher and I was the coordinator of the graduate diploma in perioperative nursing for La Trobe University. I started as an assessor for the National Standards Quality in Health when those standards were rolled out in 2011. I was an aged care assessor as a subcontractor for 10 years, and I've been doing NDIS since it was rolled out in 2020. And prior to that, I did some DHS and disability employment standard as well. I did a quick look at my audit log and I've done 430 audits today. I've been a technical reviewer for the NDIS mainly now, and I've done probably about 800 reviews of audit reports. I guess the key is non-conformities shouldn't be seen as a failure, but more as an opportunity to improve quality management systems. Obviously, if there's a large number of major non-conformities raised at an audit, then that becomes obviously an area of concern for the provider. And it's usually because the quality system hasn't been maintained. And that can happen for a number of reasons. I did an audit recently and they had grown at a phenomenal rate in 18 months. And obviously the compliance side of things sort of fell by the wayside. Sometimes it can be when there's a rapid change or turnover of staff, that kind of thing. With the NDIS, you're looking at 3 audits within the certification period. And then when you're going for recertification, there's stage 1 and stage 2 all over again. So it's quite a lot of stress for providers and a lot of audits. So it's important to maintain a system. If a provider has a robust system and process in place, an audit should be able to take place at any time. So that's why it's important to maintain a robust quality management system. Staff training is one of the strongest predictors of compliance. You can have a fantastic set of policies, but they don't keep people safe. Trained staff do. And it shouldn't be seen as an additional cost to the provider, because it'll end up costing a hell of a lot more in the long run. Believe me. When workers understand their obligations, apply procedures consistently, and confidently explain them during audits, then compliance becomes visible in practice. Strong training reduces incidents, strengthens safeguarding, and gives auditors the evidence they rely to conform. Training issues show up in a large proportion of non-conformities, often around 1/3 to 1/2. Gaps in staff competency, awareness, and record keeping consistently drive findings in documentation, process consistency, and corrective action. And it's important that a provider can somehow measure the transfer of learning. Staff can complete a quiz online and get 100%, for example, with manual handling, but can they transfer a patient, resident, or participant safely? So how does the provider measure the success of the training? Who assesses the staff that they are competent to do the manual handling transfer? You'd be looking at, has there been an increase or reduction in incidents and back injuries as a provider? And I think the fundamental one really is, who assesses the assessor and how are they assessed? How do you know that they're the right person to assess the staff? When training isn't current or evidence, it becomes one of the most common root causes auditors identify. The most common training gaps are outdated or inconsistent training, missing competency assessments, and incomplete records. Staff often rely on informal workarounds instead of the documented process, and training isn't refreshed when procedures change. And these gaps show up quickly in audits as inconsistent practice. Unclear staff responses and weak evidence during the audit. My own personal experience with the NDIS, the most common training is generally related to compliance gaps seen in the high-risk supports, such as modules 1, 2, and 2A. In aged care, when I was doing aged care assessments, it would have been the management of infections and wound care in aged care homes. With the national standards, it was the understanding and the implementation of antibiotic stewardship in the early days of the national standards. This now is less of a problem, and it's seen less and less as a gap. And as a result, fortunately, we're now seeing less resistance to antibiotics overall in the Australian community. Training gaps usually appear in audits as inconsistent practice, staff who can't clearly explain required procedures, or training records which are incomplete, outdated, or missing competency evidence. And this is going back to what I previously mentioned, the measurement of the transfer of learning. And auditors will interpret this then as a breakdown in governance. The consequences can range from minor and major non-conformities to corrective action plans. Obviously, then there's increased scrutiny because there will be a follow-up audit required and escalated risk ratings, especially when gaps relate to the high-risk supports or repeated findings. And as I said, this may require a follow-up audit to downgrade or close out the major non-conformities in the NDIS. In aged care, it required the home putting a program of improvement in place, and then the assessors would go on, a fairly regular basis to see how they were going with the implementation of that program until it's closed out. With national standards, it's the same. They would require further follow-up when there were major gaps identified. When training is built entirely in-house, the biggest risk is blind spots. I did my original nurse training in Ireland in the hospital system, and there was always that's the way we've always done it here. And I think we've all heard that at some stage of our careers. So then what can happen is the content can often drift from the legislation. It isn't benchmarked against the sector standards, and it lacks the depth that the auditors would expect. And this then can lead to inconsistent practice, weak competency evidence, and repeat non-conformities. Without external validation, governance can't be confident that the workforce is genuinely compliant. AI is the buzzword at the moment, isn't it? Generic or AI-generated training can create a false sense of assurances, so be very careful with AI. It often misses legislative nuance, it lacks sector-specific risk controls, and it really can't stand up to audit scrutiny. The warning signs are pretty obvious. No subject matter experts, no standards mapping, and no evidence of version control or competency. So this then leaves providers exposed and not compliant. So be very careful. I see it as well with audit reports. And now you can actually pick out the reports that are AI generated because they lack the traceability that the standard reports would have, like exactly the participants' files, the interviews, that sort of detail would be missing. While high quality training providers stand out because their content is evidence-based, standards mapped, and written by real subject matter experts, they assess competency and not just attendance, and align training directly to your procedures and risk profile. Poor providers rely on generic templates and no audit logic, and the good ones strengthen governance and reduce regulatory exposure. I'll give you an example. As an NDIS auditor, I see this frequently with some of the purchased NDIS packs. For example, there's 2 consultants that sell their packs, and I see in Module 1 for ventilatory management, there's a reference in their policy to undertaking chest x-rays and arterial blood gases. Well, how is this actually possible in a community setting? So obviously this has been lifted from an ICU setting and it's not applicable in the community setting. So that just gives you an example of poor, training, what it would look like. NGO Training Centre is highly effective from a compliance perspective because their training is built by genuine subject matter experts. They're mapped directly to legislation and standards, and they are updated as the sector shifts. Their programs include competency assessment, clear audit logic, and alignment to real-world practice. And then from a governance point of view for the provider, this means fewer training-related non-conformities, strong evidence of capability, and a workforce that can confidently demonstrate compliance under scrutiny. Its framework is easy to use for all staff. It's easily accessible. You even have it on your phone. And it provides management with all the data it needs to demonstrate compliance. Because during the audit, it can be a stressful time, and we're looking for, compliance rates of manual handling or enteral feeding, whatever. And, with the flick of a switch on the computer, they can pull up all that data. So from that point of view, it makes life a whole lot easier for the provider. It's that their training is purpose-built for whether it's aged care, NDIS, community services, and not repurposed from generic vet content. Each module is mapped to legislation and standards, and it's written by real sector expert, and it's updated as guidance shifts. They focus on competency and not just information, and they align training to the actual provider's procedures, which makes their content genuinely audit defensible and far more effective than template-based providers. For example, the clinically focused subjects state that when the staff member has completed the online training, for example, enteral feeding, then they also need to be clinically assessed as competent in the workplace. And this is fundamentally important for providers who need to determine who is qualified and skilled to clinically assess the workforce, and what are the key requirements that this clinical assessor needs. And importantly, and sometimes not always considered, how is the clinical assessor assessed? I've spoken with my NDIS auditor colleagues prior to this interview, and they agreed with me here. Having been on the other side when I was assessed myself, do your homework, talk with other providers about their preferred training provider, why did they choose them, and don't be just looking at shorter timeframes and budget, because that's not always the best guide here. Feedback from staff, did it meet their workplace needs? How effective was their training provider with their recent audit, for example? Was there any training non-conformities or gaps raised? Choose a training provider who can prove their content is standards mapped, evidence-based, and written by real sector experts. Look for competency assessment, version control, and that they are aligned to your actual procedure. If a provider can't demonstrate audit-ready governance, that's not the right fit.